Good evening, ladies and gentlemen. Thank you very much for joining us for this evening on modern management of thyroid cancer, a paradigm for personalised medicine. I think that's the buzzword, isn't it, in any tumour stream, but particularly in thyroid cancer. I think we're making headway into making this a real issue and a real opportunity, if you like. So I'm introducing because I'm Director of Sydney Vital, and that's the organisation hosting this evening. And Sydney Vital is a translational cancer research centre which is funded through Cancer Institute New South Wales. We are one of 7 across NSW, and the funding is for a 5-year period. And the point of funding a research organisation, which is a network organisation like Sydney Vital, is, if you like, to accelerate research and certainly accelerate what you find in research into the domain of personalised medicine, that is cancer management. And of course the whole point is to improve lives for patients with thyroid cancer, but also their relatives. So it's not just basic research, it's also research at the end, if you like, the implementation, meaning what we found, how do you get that into practice. So that's part of what Sydney Vital does. We're at the Northern Sydney Local Health District. We approximately see 12% of Northern NSW patients with cancer and treated locally at this campus at North Shore Private and Royal North Shore and some of the other public private institutes. So Sydney Vital tries to integrate with the Northern Sydney Local Health District, which has in its strategic vision to integrate clinical services, research, teaching and education, and those are the goals of Sydney Vital as well. Now the numbers are staggering. There's about approximately 5,000, so this is already somewhat old, but there's approximately 5,000 new patients that come through Royal North Shore, North Shore Private and the March Hospital. Now Sydney Vital sits as a translational centre and is a network organisation, and you can see the partners which from the top, Martin Hospital, North Shore Private, and, well, it's almost self-explanatory. And I'd like to show you what we, as a research plan, have, and that is a number of flagships that deal with issues that are germane to all tumour streams, and that is inflammation and inflammatory response to cancer, the new way of looking at functional imaging and functional treatment of cancer, which is theranostics, and then nanotechnology, which offers perhaps some future real value developments in terms of certainly personalised medicine, but also in how we diagnose and manage cancer. And we've, beneath that, we've sort of formed a number of translational centres and clinical centres of excellence. That's where we have at this campus real expertise, which may be a bit bigger or maybe a bit deeper or wider than at other campuses. And certainly thyroid cancer is one of them, pancreas cancer is the other one, and a number of others you can read. And below that we have a number of pillars that are sort of formed by teams who, again, but think on a different level about some of the issues that are, again, germane to all tumour types, like hereditary cancer syndromes, and I think that's very much a topic in thyroid cancer. So I think I'd leave it at this and introduce Professor Rory Clifton-Bly, who will take us through the evening. Thank you very much.
Thank you very much, and thank you very much to all of you for donating your evening tonight. You're very welcome at this community engagement event to highlight and showcase modern management of thyroid cancer and specifically highlight how the team at Royal North Shore Hospital integrates multiple disciplines to coordinate a streamlined approach for patients on their journey in this disease. So there is new and evolving mechanisms for dealing with thyroid cancer patients. Inherently, though, it relies on appropriate treatment choices for the individual patient. And this is what all of our speakers will highlight tonight, is how to use the information for the individual patient to create a uniquely personal treatment approach obviously optimises outcomes and reduces the risk of side effects. There are new therapies which will be discussed, but a lot of what will be discussed is less bells and whistles, but more how do we use the data that we have had always, but which we're learning how to more intelligently incorporate. Thyroid cancer, about 1,000 new thyroid cancer cases in New South Wales in 2012. This is data from the New South Wales Cancer Institute. 1 in 85 people in New South Wales will develop thyroid cancer in their lifetime. And this is a very well-known and internationally a true graph that the incidence of thyroid cancer is rising in both genders over the decades. This has truly been attributed to an increased ascertainment. That means that we're looking more for thyroid cancer, so we're finding more. And indeed, the death rates do not seem to be increasing. But importantly, for thyroid cancer, the death rates have not reduced. As death rates have reduced across so many other cancer types, the mortality rates for thyroid cancer, regrettably, have not reduced over the past few decades. The other point I'd like to highlight in general about thyroid cancer is it's a disease that strikes predominantly in the midlife, the productive and reproductive years, and I think what will be highlighted in our patient who will discuss her journey with you tonight is just the impact that this diagnosis has on work, life and family balance. It's a very disruptive cancer and because its treatment can be prolonged, it leaves a residue of effect that can be very disruptive to health and well-being. Fortunately, the mortality rates for thyroid cancer are low, but this flip side means that a lot of thyroid cancer survivors are prone over their life to developing recurrences. So recurrent disease is a challenge for thyroid cancer specialists, and knowing how to approach thyroid cancer recurrence, I think, will be a focus of tonight's meeting. And so in this journey that patients embark, often a train they don't want to board, leading to multiple different specialties, multiple different treatment paradigms, hopefully all integrated smoothly into a journey that is seamlessly transitioned from one specialist to the next. And so to introduce our team, which is a team approach at Royal North Shore Hospital in thyroid cancer management. I'll introduce our speakers individually, but in the centre there we have Bruce Robinson and Diana Learoyd, Mark Sywak and Geoff Schembri, who will discuss the differing facets of thyroid cancer and its comprehensive management. To begin though, I'd like to invite Amber Arnold-McCroby to the podium to discuss her own personal journey and fight with thyroid cancer. Thank you very much, Amber.
Thank you. Hi everyone, thanks for coming tonight. I'm Amber, I'm a thyroid cancer patient and I live and work on the Central Coast, but I've been lucky enough to have had the majority of my treatment right here in Royal North Shore. My patient journey started in 2008 and I had a few lymph nodes in my neck that were slowly growing in size, probably over 4 or 5 years. I finally had them biopsied and a thyroid biopsy done and a chest CT scan. From that, I was diagnosed with thyroid cancer. It had spread to my lungs and many of the lymph nodes in my chest and neck. So it was quite overwhelming at the time to be told you had quite extensive disease. I just returned from an extended overseas holiday, making plans to get married and buying a house and all those sorts of things. And it was just really overwhelming. I had to see lots of surgeons and endocrinologists and radiologists in a short period of time. So I realise now, you know, in hindsight, it's often, I think, how important knowledge and support would have been at this time. What followed for me was some fairly extensive surgery, a total thyroidectomy and some neck extension and one of many radiation treatments. I initially found the radiation treatment isolating and I became quite unwell physically and mentally. I now understand this was due to withdrawing from the thyroid medication in the weeks leading up to your treatment and afterwards. It was after a second radiation treatment with radioactive iodine that I had increasing concerns about how often the treatment would be and whether my dosing was appropriate. And I was really getting sick of hearing, oh, you've got thyroid cancer, no one dies of that, or it's got a great, survival rate. I was confused about what scans were best. You hear words like CT and PET, and I often had concerns about whether my dosing of the radiation was appropriate. I was also had a lot of concerns about fertility, being young at the time, and also whether I was taking my medications properly. One of my good friends encouraged me to join a support and education group, which was the Australian Thyroid Foundation. This was great. I got so much information on the whole process, and I couldn't believe how many other people, especially young women, had thyroid cancer. It was a real turning point for me. I was referred to an excellent endocrinologist right here at Royal North Shore, Bruce Robinson, and I felt my concerns were listened to and more was explained about the various treatments, doses and timing of radiation, the blood tests, effects on fertility, and what I needed to do, what needed to be followed up and when. One of my big concerns was reoccurrence and whether I would stop responding to radioactive iodine. So it was really good and assuring to go over other treatment methods and other options. I was also given information and more choice about the use of Thyrogen. So many of you will know Thyrogen is a medicine that safely replaces the need to withdraw from thyroid hormone without any of the awful side effects. This made an enormous difference to my physical and mental state during the radioactive iodine treatments. I did need many more doses of radiation as my disease was quite extensive. And initially I had larger doses of radiation probably every 6 months or so. And then these reduced and became further apart as the disease, I started to respond to the treatment. And also being a details person, I found the nuclear medicine staff here were really helpful. They went over all my scans with me in great detail and consulted after each treatment, explaining the location and the responses. Currently, I'm in the follow-up stage with yearly small dose scans. So far, the scans have been negative with only small levels of remaining thyroglobulin. I understand that I need to continue with follow-up scans, and possibly at a future date, I may even need more treatment. I'm healthy and well otherwise, and my husband and I have even been lucky enough to have a little boy. I feel I had a tailored medical treatment that was appropriate to my circumstances, something that all thyroid cancer patients should be afforded. Thank you for your time, and I'd be happy to answer any questions later in the evening. Thank you.
Right. Well, that set the scene beautifully. A very eloquent description of a patient facing the difficult journey with thyroid cancer. So to start the clinical part of the evening, I'd like to welcome Associate Professor Diana Learoyd. Di is an endocrinologist who's been at Royal North Shore for several decades, and she vastly experienced. She completed a PhD in 1999 in the genetics of thyroid cancer and in multiple endocrine neoplasia type 2. She set up the thyroid cancer clinical database at Royal North Shore Hospital with the New South Wales Cancer Institute grant, and she's had a major role in the TKI trials that we run at Royal North Shore Hospital for both papillary follicular thyroid cancer but also for medullary thyroid cancer, the different subtypes of thyroid cancer that we see. She co-runs the Thyroid Cancer Multidisciplinary Clinic at Royal North Shore Hospital together with Mark Sywak, and she's got an extraordinarily busy and diverse clinical practice in general endocrinology but with a focus on thyroid cancer management. Di, thank you.
Thank you very much. It's a great honour to be here, and it's great to see the audience. It's also good to redress the gender imbalance on the panel, given that we deal with so many women as patients. But so, yeah, as the token female, I'm very honoured to be here. So this is my topic, who needs minimal treatment? And I'd just like to draw your attention to my declarations there. And also, I'm aware of the fact that in the audience there are some non-medical people. Can you put your hands up? Yep. So I won't be going through the very basics of thyroid cancer management, but we do have a handout, which is this article that we've recently written, which is fairly user-friendly for people, whether you're expert or not in the area. So how do we minimise therapy? So we minimise it by not doing any surgery in a thyroid cancer patient, by doing a hemithyroidectomy, so half the thyroid is removed instead of the whole thyroid, by doing a total thyroidectomy without radioactive iodine, or by doing a total thyroidectomy with a very low dose of radioactive iodine. Now, this is in contrast to what we used to do, which was one size fits all. And yes, I have been around for several decades, and so I remember the sledgehammer approach, where every single patient, no matter what their age or stage, received total thyroidectomy with 6 gigabecquerels or 150 millicuries of radioactive iodine in the old days. Nowadays, it's all very different. It's tailored and it's individual, and it's based on evidence. And why is that? And that's because we don't want to be in this scenario where the treatment is actually worse than the disease. And that's particularly relevant for thyroid cancer, where the outcomes tend to be very good with minimal treatment. And you just need to be aware that there are some long-term sequelae. They're very unlikely, Amber, so don't worry. But yeah, we try to go with the best possible evidence and the minimum treatment that will work. And Rory's already alluded to this. Thyroid cancer is becoming more prevalent. It's a disease of all ages, but it particularly affects middle-aged women, and it affects women in their childbearing years, and that's very relevant to how we approach management. So we really do have to tailor our management to whether a woman or a man is planning a family and when they might want to have children. However, the news is that the outcomes are excellent. So no matter what type of thyroid cancer or stage, you are unlikely to die of it. If you have low-risk thyroid cancer, the death rate is close to 0. If you have high-risk thyroid cancer, it's still less than 50%, although along the way, it is quite likely to recur. So you may need to have more than one mode of therapy at more than one time point. If you're diagnosed under the age of 55, your 10-year survival is very close to 100%, and even if you're diagnosed with distant metastases at that age, it's close to 85%. So it is pretty good news. Not always. In older patients, not so much, but in young patients particularly. We're very lucky that we have evidence-based guidelines from the Americans that help us in our approach to tailored management. So these guidelines have been going for quite a few years now, and they're very comprehensive. They're updated regularly. The Americans, particularly this guy, put a lot of effort into them. In fact, Michael Tuttle has said that he's now spent so many weekends on doing guidelines that his wife's threatening to divorce him. So we may not see the next version with him on it. So how do we come to see these patients? As you all know, we see them because they present with either a lump or they have an ultrasound finding such as this, or both. And this is a thyroid cancer. You can see it's between the artery and the trachea. It has an irregular border, and a patient with this finding will then proceed on to have a fine needle biopsy plus or minus an operation, which may be partial or total thyroidectomy with or without lymph nodes. I'm not going to go into cytology or pathology or choice of surgery tonight, but that may come up in the discussion. And I also don't want to impinge on Mark's talk. So as an endocrinologist, we often see the patient pre-op, but we always see the patient post-op. And we may or may not have the benefit of a histopathology report that includes the lymph nodes. And we're very lucky at North Shore that our surgeons routinely remove central lymph nodes if they know the patient has cancer up front, and they can do that with very minimal morbidity as opposed to some centres around the world. I'm very indebted to Lee Delbridge for his slide where he's nicely illustrated the central lymph nodes that are usually routinely removed, and that allows us to have a bit of a better idea about staging. So the cross has moved. So what I want you to know is that cervical lymph nodes are not metastases, so the cross is meant to sit on top of the word mets. They're very common, particularly in papillary cancer. So papillary cancer is the commonest cancer, it's the best prognosis, but it has the highest incidence of lymph node metastases, and despite that it does very well. Less so in follicular and Hurtle cell. Lymph nodes are concerning, but they're not always bad. They don't upstage your risk unnecessarily if your tumour itself is low risk. And they have minimal impact on your TNM stage, ironically, if your tumour is low risk. We also have thyroglobulin, a blood test, which is a very useful tumour marker, and it responds to therapy over time by going down to 0, hopefully. We can also measure it in fine needle biopsy washouts. So if someone has a recurrence suspected in their lymph nodes and the cytology is equivocal, we can actually measure thyroglobulin in that lymph node washout to get extra sensitivity on diagnosing recurrence. We also have very good assays for serum thyroglobulin now that detect thyroglobulin levels less than 1 microgram per litre, although we do have to be a little bit careful about thyroglobulin antibodies, which interfere with the accuracy and falsely lower the result. I think most of you in the audience will be aware of that, of this thyroglobulin information. Okay, so in terms of who needs minimal treatment, people with low-risk disease will need minimal treatment, and I will be moving on to describe some cases that I currently manage. And in the guidelines, this is what is listed as low risk. So it's logical. All the tumour has been resected, there's no local invasion, and it's not one of the unusual aggressive histological variants, which I won't go into. And we now have some new categories that have crept into this low-risk category. So the low-risk category keeps expanding, which is really good news, as we get extra information from trials to show that some things are not as bad as we thought they were. So, for example, you can now have some vascular invasion with an encapsulated follicular cancer and still be very low risk. So it's good news. Intermediate risk is any of these things, and now in the latest iteration of the guidelines, you have to have clinical lymph node involvement to have intermediate risk, and these things also logically will upstage you to intermediate, such as tall cell variant, etc. Vascular invasion on the pathology concerns us and usually upscales you to intermediate risk, except for the example I've already given you for low risk. And in the latest guidelines, we actually, for the first time, have the mention of this genetic mutation called BRAF, which you'll be familiar with, is a common mutation in other cancers. It's quite common in thyroid cancer, specifically papillary thyroid cancer, and it actually does rate a mention now in intermediate risk category. I'm not going to go into that in great detail, but I will make the point that risk is always reassessed. So when you stage someone at the beginning, you may think they're high or intermediate risk. If they respond beautifully to treatment after a year, you can downstage them to low risk. So it must be reassessed dynamically, and there's good data now to show that delayed risk stratification according to their response to treatment is a much better way of predicting their outcome rather than just going on what happened right at the beginning. I won't say much about TNM. It's about to be upgraded to edition 8. I don't find it particularly useful myself. It's used in other tumours. It's designed to look at mortality, which doesn't really suit thyroid cancer. It's very black and white. If you're under 55, everything's great. If you're over 55, suddenly it all changes, and we know that's not really how it happens. So TNM, not that useful in my experience. We've also just changed the magic age from 45 to 55, so it's a little bit arbitrary. In reality, though, it's much more like this. So it's a gradation of risk from the best possible risk, which is a unifocal micropapillary cancer, right up through low, intermediate and high, up the top here. Don't worry about reading that. That will put you to sleep. Okay, and the other things that we consider, apart from what I've already mentioned, which is age, stage and histopathology, we also look at gender. Unfortunately for you blokes, men tend to do a little bit worse than women. Family history is very important. Radiation exposure to the neck is also very important. And genes are becoming more and more important, and I'm sure that will be covered a little bit later in the high-risk sort of patients that Bruce will probably cover. So you probably already know that if you've had external beam radiation to your neck as a child, that your risk of thyroid cancer is significantly higher than the average population. And also if you've been exposed to nuclear fallout, such as Chernobyl in 1986, or even Fukushima. We're now seeing some data from Fukushima in Japan from coming through now for thyroid cancer. Luckily, most of us here haven't been exposed to that, although I did see a patient on Monday who actually lived in the Ukraine in 1986, who migrated to Australia in 1996, so you never know when it might come up in the conversation. And genetics, again, I won't touch on this in detail. So BRAF, I've already mentioned as in the intermediate category. What does it actually mean? It's very common in thyroid cancer. It's common in very low-risk cancers, and it probably doesn't help to know your BRAF status if you're very low risk or high risk, except perhaps for tailoring treatment in high-risk patients. But we think that it may have some prognostic utility in intermediate. So these are the patients who maybe have lots of lymph node involvement. We're not really sure how things are going to behave in the future, and how to give them an idea of how they're going to travel. That's all I want to say about that, except to show you this, this slide. So Anthony Gill in our pathology department at North Shore routinely does BRAF immunohistochemistry now on all papillary thyroid cancers. So radioactive iodine is the other area, and Geoff will cover this later, and I won't go into detail. The guidelines state fairly clearly radioactive iodine is fairly routine for high-risk patients. For low-risk patients, we no longer recommend radioactive iodine for unifocal or multifocal papillary microcarcinoma, that means less than a centimetre, in the absence of other adverse features, and the literature would support this. And it's not recommended for patients with low-risk differentiated thyroid cancer in the absence of other adverse features. And there are some ongoing studies that will hopefully reiterate that. We consider it in intermediate risk patients. We tend to give it at North Shore because I think we're sort of used to doing that and people do well. But the evidence now is that we don't always have to give it as much as we did. This is a patient of mine who looked like he was going to be low risk because he was young, but he had previous radiation to the neck and he had vascular invasion on his micropapillary cancer. And after radioactive iodine, I'll just go back up, we had an unexpected finding of a lymph node that had been sort of left behind. This is some years ago. So, and he's been cured just with a single operation and single dose of radioactive iodine. And the dose is very controversial, and Geoff, I'm sure, will cover that in great detail. We have two very good randomised prospective studies that were published in the New England Journal 5 years ago that helped to clarify that for low risk and intermediate risk disease, a low dose is perfectly adequate. So 1 gigabecquerel, which is 30 millicuries, is just as good as 4 or 100 millicuries. And there's ongoing evidence now, so 5-year follow-up from this particular study, the European study, the French study, is very reassuring, and the British study also included intermediate grade disease. However, old habits die hard, and I've done a snapshot of what we're doing at North Shore, and we're still giving quite a lot. We're giving 4.2 gigabecquerels on average for low to intermediate risk disease, so perhaps we need to gradually move into the 21st century, and I'm sure that will happen eventually. No, most of us are giving low doses for very low risk. I won't go through the guidelines or you'll definitely fall asleep. They don't really help you a lot for intermediate grade disease. They use a lot of C words, conflicting evidence, and consider giving radioactive iodine, although they're fairly clear that you don't need to do it for low risk and you probably do need to do it for high risk. So, in the last few minutes, I just want to describe some cases. These are cases I'm currently looking after. First is an incidental finding of a thyroid cancer on PET scanning. This lady is 78. She was seen 6 years ago having investigations for another malignancy. A routine staging FDG PET scan uncovered a hot area in her thyroid, And we see this commonly, so I think the prevalence is about 2.5% for hot thyroid uptake in PET scans performed for other reasons. Interestingly, she actually did have thyroid nodules, and most 78-year-old women will have thyroid nodules on ultrasound, but the hot area was not in a nodule. So the FDG PET uptake was not avid in the known dominant nodule in her thyroid, but it was just above there, and I'll show you that later. If someone has a hot nodule on PET in their thyroid, they've got a 1 in 3 chance of it being cancer. And this is this lady, and this is the area in her thyroid. And she was very keen to have slow or conservative management, so she actually waited a whole year to have a biopsy. We finally got around to doing that, and yes, it was cancer, and there it is again on the PET scan. And this is the ultrasound. So this is not a very good view, but you can see this is the nodule here that you could see on ultrasound, but it's not PET avid. This little area here where there's a bit of calcification was the area hot on PET. That was biopsied, and that was the cancer. She did see a surgeon, and she chose not to have surgery, and 6 years down the track, serial ultrasound has shown no progression, no discrete nodule, and she's perfectly well. And this approach is now quite well supported in the literature, particularly with the Japanese literature. So the Japanese have studied micropapillary cancer, also particularly in older patients, to show that often it just grumbles along and doesn't necessarily need intervention. And people in Melbourne have also studied incidental PET uptake in patients who have other cancers to show that you don't necessarily need to intervene, particularly if the prognosis for the other cancer is more guarded, because thyroid cancer tends to behave much less aggressively. Case 2 is a patient with multifocal micropapillary thyroid cancer, and this is a lady I just saw recently. She's a female physician who works at this hospital. All her family are doctors, seems to be typical of my practice. She had a lump in her thyroid which got bigger postpartum, and she had a benign biopsy, so she had what we call Bethesda category 2, so that doesn't worry us. However, the lump got bigger and was causing pressure. So she came to surgery for obstructive symptoms. She had a left hemithyroidectomy, and the lump was benign. So the dominant lesion was 3.5 centimetres. It was a follicular adenoma, which is benign. An incidental finding was made of 2 papillary microcarcinomas, 1 millimetre or 1.1 and 1.2 millimetres. And the decision we've made together is that she's very low risk and that she will have hemithyroidectomy alone without total thyroidectomy at this stage, but with regular monitoring. And this is her ultrasound showing a very benign looking but large nodule in the left lobe, isoechoic with a clear border. That was Bethesda category 2. It came out for other reasons, and incidental finding of microcarcinoma, which you wouldn't even expect to see on an ultrasound. A similar but different case, another woman in her 40s, she did have an abnormal fine needle biopsy. She had category 4, which is a topic in itself. I won't go into that tonight. So she had a diagnostic right hemithyroidectomy for an atypical biopsy, and she did have a cancer, and it was 1.8 centimetres, encapsulated follicular variant of papillary cancer with some Hürtel cell features. So this is slightly complicated. It looks like a papillary cancer, but it also looks like a follicular cancer. And luckily, there was no extrathyroidal extension, no vascular invasion, BRAF negative. And again, she has elected to have conservative management, hemithyroidectomy alone, and regular monitoring. In the old days, she would have had a completion thyroidectomy, a second operation, and a dose of radioactive iodine automatically. Case 3 is a patient who is very anxious. I think her father's actually a doctor, coincidentally. And Murphy's Law has been pretty unkind to this lady, and she and I have been through a lot of anxious times together. Anyway, long story short, she's 30. She has Hashimoto's disease, which is, as you know, is the autoimmune disease, which is very common in young women. She is antibody positive, and she had her first baby last year and then developed severe postpartum thyroiditis, which is not uncommon. It's about a 30% risk in women who have Hashimoto's disease. However, she, being she, was particularly unwell. She had very high thyroid hormone levels. She was very sick. She did not tolerate the treatment we normally give, which is beta blockers. She actually ended up in Prince Alfred casualty with a systolic blood pressure of 60 after one dose of Indoral. And I actually treated her with steroids, which is the first time I've ever given steroids for postpartum thyroiditis. And she got better very quickly, fortunately. Now, I never biopsy people with postpartum thyroiditis because the gland is very heterogeneous and there are lots of areas that actually improve and the swelling goes down. But she had a residual mass in the middle of her neck, which was quite firm 6 months later. And we biopsied that, and Murphy's Law being the way it is, it was a Bethesda Category 6 biopsy or a papillary cancer. So, of course, she now had to proceed on to total thyroidectomy. Well, did she need to have total thyroidectomy? In this case, I can assure you yes is the answer, knowing her and her family. She had total thyroidectomy with a central node clearance and fortunately was low risk, although she was multifocal disease. So she had a 1.1 centimetre cancer. Also, she had 0.5 centimetre and a 0.1 centimetre papillary cancer with no nodal involvement. She was still breastfeeding, I might add, from the baby last year. And she, again, is low-risk disease. I actually told her she didn't need to rush into having the operation, but she, being she, had it within a week. Thank you, Mark. You do provide very good service. So at this stage, there are no plans for radioactive iodine unless her dynamic risk reassessment actually changes. And at the moment, things are going well, except that because she's antibody positive, we can't accurately monitor her serum thyroglobulin. So her antibodies are positive, but they are waning, so I'm very hopeful, and I'm trying to present it in a positive light because I think she's completely cured. And this is her ultrasound. So you can see she's got a big swollen heterogeneous thyroid from Hashimoto's plus postpartum thyroiditis, and this was the area in the middle that was the papillary cancer. And it was clinically suspicious, although you wouldn't really be able to distinguish that from the rest of the scan. So I probably will finish up there. I'll just mention the last case very briefly. This is another young female who was actually diagnosed during pregnancy, operated on at another institution, told by her surgeon, who's not in the room, that she needed radioactive iodine. It was a no-brainer. And in fairness to him, I think there is considerable confusion now about what constitutes low risk. So I'm not passing judgment on him because he's has her best interests at heart. But at the time, she was pregnant and planning to breastfeed. So all those sorts of decisions are very traumatic for a woman who's got an unexpected cancer diagnosis during pregnancy. So she came to see me with this pathology, for a second opinion, 2.5 centimetre papillary cancer, classical with 1 out of 11 central nodes involved. And I saw her at the end of pregnancy. She then delivered a healthy baby and started breastfeeding. And her thyroglobulin postpartum is completely negative, and we have no plans to give her radioactive iodine unless we really need to. And she has, I think, had trouble accepting that opinion and has sought a third endocrine opinion, but hopefully she'll be fine. So I'd just like to finish. Who needs minimal treatment or no treatment? No treatment is appropriate for elderly patients where the thyroid cancer is very small and not likely to cause any trouble in their lifetime, or in patients who have an incidental finding on PET, particularly if their other cancer has priority. Minimal treatment such as diagnostic hemithyroidectomy is appropriate for encapsulated tumours without vascular invasion, or even for low-risk papillary cancers, and that may include multifocal papillary cancers. And low-risk patients can also have total thyroidectomy without radioactive iodine, but as long as we dynamically reassess them. So we never say goodbye, we keep seeing them. And we also know that from the literature, if we have to do catch-up therapy later on, it probably doesn't matter. So thank you, and thanks to my colleagues.
It was fantastic, Beautiful slides. I'm going to nick some of them from you if you don't mind. What a wonderful way to introduce the clinical approach to thyroid cancer. Our next speaker is Dr. Geoff Schembri, Senior Staff Specialist in Nuclear Medicine at our hospital. He's been involved with a large range of research optimising lung imaging for pulmonary emboli, the role of PSMA in initial staging and restaging of prostate cancer, and the use of PET imaging in the diagnosis and management of glioma. Therapy has become an increasing part of his clinical practice, including iodine for thyroid cancer and also lutetium-based therapies for neuroendocrine tumours. Geoff Schembri, thank you.
Thank you. I'm going to apologise if I cough. I've had the bug, but recovering. So thyroid cancer, where are we going with therapy? I'm sort of going to try and take you through a bit of a cook's tour of nuclear medicine and therapy, and hopefully give you a better understanding of what we're about. So everything starts on an evening with a good fairy's tale. So once upon a time, if you had a broken leg, they put it in a cast. And if you had breast cancer, you had mastectomy. And so there was one treatment, and that's what you got. Because if someone ate your leg, there wasn't quite as much as we could do for you. Now, if you voted for Trump, then you had to have a frontal lobotomy. Or maybe I've got that backwards. So, things have changed, and now we have a lot more options available to us. Sure, you might still get that cast, but there are other ways of fixing broken legs, from nails to plates to rather more extravagant bits of surgery. And for breast cancer, sure, mastectomy is still there, but there's lumpectomy and radiotherapy and chemotherapy and hormone therapy and immunotherapy. So there's now multiple options available to us, and what we need to do is try and pick which of those is the appropriate treatment for the appropriate patient. So why is this all changing? What's happening? There's a whole range of new classes of drugs that are becoming available to us. We're characterising tumours much better, and you may hear this word genomics. We're now looking at the DNA structure of tumours. And the interesting thing we're learning is that not all tumours are the same. Just because you have breast cancer doesn't mean that your breast cancer is exactly the same as somebody else's breast cancer. And indeed, one treatment that works perfectly well for one subtype of breast cancer may be completely useless in another. And so we need to identify a bit more carefully what we are treating, and that means that we can target the therapy and hopefully get a much more specific response to the therapy that we give. Now, thyroid cancer, radioiodine therapy has been around for a long time, and you may have seen the buzzword theranostic. Theranostic means an agent that we can use for both therapy and diagnosis, and indeed iodine was the very first of this. It was an agent we used to scan thyroids to find problems, but it was also an agent that we could use to treat thyroid cancer and other thyroid diseases. It's been around since 1941, and as Di alluded to, really, you pretty much got hit with a sledgehammer. In fact, we did have two sledgehammers. We had the medium sledgehammer and the heavy sledgehammer. And we just used one depending upon whether we thought you had disease in the thyroid or whether the disease had already spread. But it was pretty basic stuff. But hang on a sec. What is radioiodine anyway, before we even get to talking about how we use it? All elements in nature exist in various isotopes. So you have isotopes of carbon and other atoms. The good thing about isotopes is it's exactly the same chemically as a normal element, except usually it has more neutrons. And what that means is we can actually use an isotope and it will behave just like the normal element, but we have changed it so that we can either use it for treatment or for taking pictures, seeing where it goes. Usually the isotopes are radioactive because they've got too many or too few neutrons, and they release radiation, and that allows them to change their atomic number and become a bit more stable. These are three of my favourite elements, and they form one of my favourite compounds. So when we talk about radiation, there's three typical forms of radiation that we deal with. So there's gamma radiation. So gamma radiation are gamma rays or X-rays when they're produced artificially. Beta radiation, which is simply an electron being released from the atom. And alpha radiation, which is actually a whole helium nucleus. So it's two protons and two neutrons. So all of these are what we call ionizing radiation. What that means is as they pass through your tissues, they ionize the material in your cells. And it's that ionization is what causes the damage that it will eventually lead to cell death. Now, the bigger the particle, the more damage it does, and the less distance it can travel in tissues. So that means gamma radiation, which in fact is not a particle at all, has very long range. So as we all sit here in this room, we have gamma radiation passing through us. And through most of the time, it's not stopping. It's just going straight through and on, and probably won't interact until it gets many light years away from here. So we use that in our imaging. Now, beta radiation is a much shorter range. It's a couple of millimetres, and so you can target reasonably well with using beta emitters. And alpha give very high energy almost exactly at the source of origin. So it's very good for targeting, but it does do a lot of local damage. Radioactive iodine is both a beta and a gamma emitter. So we use the gamma for taking the pictures and the beta for the therapy. Now, thyroid takes up iodine. In fact, it uses that iodine to make the thyroid hormones, and that's stored in the gland. Fortunately for us, many of the tumours also still take up iodine, so what we call iodine-avid tumours. And that means we can give this isotope of iodine and target them with the radiation and hopefully destroy the tumour cells. But hang on, radiation, is that safe? Well, I think it's safe. I've been working with radiation all my life, and sure, I used to be 6 foot tall and have hair. But as far as I can tell, it's had no adverse effects whatsoever. So we live in a world that is full of radiation. And some people would like to make it more full of it. Our bodies are perfectly adapted to a low radiation environment. But high levels can certainly overwhelm repair processes, and that's what we rely on when we're treating cancer. So we try and overwhelm the cancer and minimise the injury to normal tissues. By the way, you do know this is just steam, right? I was put those photos in there. It looks pretty scary. So as Di showed you, radioactive iodine, we get scans that have this kind of appearance. And you can see that you get uptake in salivary glands, in the stomach, in the bowel. You get excreted through the urine, so it's in your bladder. So you might think, well, when we're treating someone with radioactive iodine, are we going to damage all these other structures as well? Certainly salivary damage is a potential complication. Luckily for us, most of the other things there are pretty resistant to radiation, and it's very rare that we'll see any issues with that. Other things we need to be aware of are cancer induction and fertility. So let's talk a bit about salivary glands. Salivary gland problems are the most common problem of radioactive iodine therapy. Up to half the people that we give radioactive iodine will get some symptoms in the first 12 months. Not sure if Amber got any, but she's nodding her head over there, so I don't think she did. So that's usually pain or swelling, a dry mouth, altered taste. And about 16% of patients will still have symptoms at 5 years. So this is a real complication and something we'd like to minimise. One thing that is definitely shown, the more you give, the higher the chance you'll get salivary gland problems. So here's one good reason to try and give less radiation if we can. Secondary cancers. Now, even if I don't give you radioactive iodine, there is an association between having one type of cancer and other types of cancers regardless. So you have to correct for that effect when you're trying to decide if there's a genuine effect from the radiation. However, while there is some mixed data, I think that we're pretty happy that there is some increased risk. One study said that the risk was only there when you had lots and lots of doses, so up to 37 gigabecquerels. A standard dose that we give is between 1 and 4. One study that looked at breast cancer in particular showed no increased risk of breast cancer. That was good news. But certainly it does appear to be some slight increase across a range of cancers, though again, not with single dose therapy, but once you get to multiple dose therapies. And almost all of these show a dose response. The more you give, the higher the risk. So again, a good reason for trying to minimise the dose. What about fertility? Well, for men, you can get a transient reduction in sperm for up to 18 months. Permanent infertility almost never occurs, and there's very little effect just from a single dose. In women, you can get transient amenorrhea in about a quarter. It can bring on menopause a little bit earlier than normal. And we normally recommend that you delay pregnancy for about 6 months. That's not because of the radiation per se. That's because if you need a second dose, we don't want you to be pregnant and unable to give you the treatment that you need. So why are we going to give it? So there's a couple of reasons why we might like to give it. Managing cancers is often easiest when you have a marker for that cancer. So for prostate, we have PSA as our marker. For thyroid cancer, we use thyroglobulin, which is a protein produced by the thyroid glands. Now, in a perfect world, you would hope the surgeon would take out the whole thyroid gland. But even the best surgeons, even Mark, can't get all of the thyroid out because sometimes there's these nerves, and patients like to talk after the surgery, and there are blood vessels in that area. And sometimes not all the thyroid's exactly where it's meant to be, but there are little remnants left around. So you just can't get all of it in every single person. So reason one, we give radioactive iodine to complete the surgery, to get rid of leftover normal thyroid tissue. So we're not thinking this person's got cancer, we're just cleaning up, and that allows us now to use thyroglobulin as a tumour marker. Now, the alternate scenario is where we didn't get all the cancer, and we'll go through some of the things that make us think that, but bits of cancer may be left in the thyroid bed or in lymph nodes or in distant sites. And in some patients, it can be in the lungs, and in others occasionally in the bone. So if you have residual cancer, there has been studies that show giving radioactive iodine will improve your survival and reduce the risk of local recurrence, of the cancer coming back locally. So if we think you have cancer, then we will give you radioactive iodine to improve your long-term outcome. So as we sort of already covered a bit tonight, we now know that not all cancers will benefit the same. In fact, many of them do perfectly well with no treatment, and low-risk cancers do not need radioactive iodine. So how do we know who needs it and who doesn't need it? Well, this is not Anthony Gill. We try and categorise the cancer into groups of low, intermediate and high risk, and we do that by looking at the histology, what kind of cells are in there. We look at where those cells are found. Have they spread outside the thyroid, into vessels, into lymph nodes or lymph vessels? And we look at the genetics. And occasionally we'll even talk to the patient. The patients will often have an opinion. Some of them will want therapy. They go, I don't care, I just want to have it. And others are terrified of having radioactive iodine therapy. And we have to balance their concerns when we're deciding what we're going to give them. Are they young? Are they old? Have they got other issues that we need to be aware of with their health or their families? What's their straightforward preference? The thyroglobulin level, the higher the level is post-surgery, the higher the chance they might recur. So in my head, whenever I speak to the patients, I try and form the question and answer the question, do I think they've got residual cancer? Yes, they need this dose. Am I just cleaning up any leftover thyroid tissue? Yes, they need this dose. Are they low risk? They don't need anything. Why they get sent to me? Okay. And look, same side as dye, so I'll skip that one. Now, we know that there's some risk of therapy. We know that risk does have some linearity with dose, so the higher the dose, the higher the risk. And therefore, we want to try and give low doses to some people and high doses maybe to others. So we're going for the Goldilocks effects here. We want to get it just right. So the two trials... Will Emily Hibbett stop coming? Go away, Hibbett. So the two studies, there's the HILO trial. And this was quite interesting because two trials came out in 2012. One was from the Brits and one was from the French, and so there was all sorts of fun at the meetings with those two groups. And what did they find? Look, they looked at low rates and they compared a 1 gig dose to a 4 gig dose effectively, and they showed essentially there was very little difference. So if all you're worried about is getting rid of thyroid tissue, you can do that effectively with 1 gigabecquerel. And that has a few benefits, not just from the lower radiation. The patient needs to stay in hospital less. They can go home the next day. So that's actually a benefit for the cost to us as healthcare providers, but also to the patients. So we know that some cancers are cured by the surgery. They don't need any other treatment. The low-risk ones, as we've sort of already discussed, these are the small solitary cancers, no nodes, or small, with some lymph nodes, but not too much lymph node involvement. If it's multifocal, but they're all tiny, then we would not recommend routine radioactive iodine ablation in these patients. And if someone really, really wants something done, then we'll give that low-dose therapy. And there's no evidence of benefit of radioiodine in this group. What about the intermediate risk group? So we've already sort of covered a little bit about what makes these things more intermediate, but it's pretty obvious. It's when they've started to spread, either directly or through significant nodal involvement, or they've got those more aggressive subtypes, or they've got the mutation. Then I think we would mostly say, okay, well, we're happy to give them radioactive ablation, iodine, and there is certainly some evidence to show these patients will have improved survival if you do that. And if we're not too worried, they might get a low dose. If we're a bit more worried, we might give them a 4 gig dose. Look, high risk, definitely I think all of us here would probably agree they need cancer. Therapy, I'm not going to go through all the things, but there's definitely, I think, evidence to show that they will get some benefit in general from treatment. Now here at North Shore, for nuclear medicine, we treat about 150 patients a year, so that means out of the 250, 300 patients getting cancer, only about half of them are coming to us for treatment. Just to show, we are doing some improvement. In 2011, 25% were getting low dose. Now we're up to nearly 40%, and 55% were getting high dose, and that's come down to about 40%. So we're shifting, but maybe we haven't shifted quite as quickly as we should. So that's all I was going to talk about today. And
should emphasise that there'll be plenty of opportunities to ask questions at the end. We have a full panel discussion coming up. So our next speaker is Associate Professor Mark Sywak, a specialist endocrine surgeon focused on the treatment of patients with thyroid, parathyroid and adrenal problems. He's a graduate of the University of Sydney Medical School and a Fellow of the Royal Australasian College of Surgeons. He's the head of the Department of Endocrine and Oncology Surgery at North Shore and Clinical Associate Professor at the University of Sydney. He's got a strong interest in thyroid cancer research and is heavily involved in surgical training as the Supervisor of Surgical Training for Northern Sydney Rotation of the College of Surgeons. Mark, thank you.
Sorry. Thanks so much to Rory and Alexander for asking me to talk today. I knew that by the time I got to speak that... oh, that's the wrong one. That most things will be covered. So I'm going to have a good crack at giving Bruce Robinson's talk right now.
Slide is on the...
This one? Yeah.
No, I think yours is on the laptop. Can I just do this?
Yep. That's mine.
Yes. So,
Okay, so I've been asked to speak about surgery for high-risk disease, but in fact, I'm going to talk a little bit about the historical aspects of nuclear testing, because I was so impressed by a talk that Mark Tuttle gave us a couple of years ago that I thought it was a story that was definitely worth repeating. We'll talk a little bit about ultrasound, and I will speak about surgery. These graphs we've seen exponential rise in thyroid cancer around the world, really, and you'll note from this slide that in New South Wales, we're kind of in the top 5 precincts around the world in terms of thyroid cancer incidence. And we certainly feel that every couple of weeks when we do our thyroid cancer MDT. Lifetime risk of about 100, between 80 and 100. And Rory showed this slide. The number of actual deaths from thyroid cancer are low, but the backstory is that we have a huge number of thyroid cancer survivors who need long-term follow-up. So in that period, 1980 to 2006, there were 18,000 thyroid cancer survivors, all of whom have an endocrinologist, an annual or a twice-yearly visit, biochemistry, anxiety that comes along with all of those visits. So there's a lot of resources that are consumed and needed to maintain those patients. The thyroid cancer story is very closely linked to radiation, and we learnt this after the Hiroshima accident, but in many ways the world was a very different place after July 16th, when the Americans, as a culmination of the Manhattan Project, exploded the first plutonium bomb in New Mexico. A month later, the bomb was detonated in Hiroshima, 1945. And I think those stories are very well known, but the thing that surprised me when Mike Tuttle gave this talk was just the sheer number of bombs that were exploded in the South Pacific. And I think most Australians don't really understand that. But the Marshall Islands are just here, just south of the equator. And the Americans used the Marshall Islands as a testing site for their nuclear program during the Cold War. And you'd be surprised to learn that between 46 and 58 they exploded 66 nuclear weapons. And they weren't underground, they were into the atmosphere. And they chose the most beautiful spot, the Bikini Atoll. The most famous of those bombs was called Castle Bravo, a 15 megaton bomb. They exploded in 1954. They were really experimenting with these things, and they found out the results of this experiment really were that they created 2.5 times larger blasts than they anticipated. They irradiated a whole number of islands around it. Marshall Islanders had to be evacuated. There was a Japanese fishing trawler that happened to be going past at the same time. Most of them died from radiation sickness. It's staggering when you look at how many bombs were exploded in our backyard in that time period. So these are all atmospheric nuclear tests. Marshall Islands, 65. In Australia, we had 7 bombs exploded in Maralinga and 3 at the Montebello Islands, Mururoa and Christmas Island. I'll show you a picture of the radiation that drifted from the Fukushima accident, but there must have been significant contamination of the atmosphere in our area in those years. Chernobyl, 1986. You can see that the Russians kept it very quiet for a few days until the radiation started to head up towards Sweden, and the Swedes rang up and said, "Are there any problems down there?" And they said no, but finally they had to fess up. But the radiation ultimately spread all over Europe, and Belarus copped a big amount of it. Fukushima, 2011. This is just an illustration showing what happened when, as a result of the wind, there was actually contamination all the way across into California. Very, very mild and not dangerous, but real. So if you just look at the amount of radiation that was released in those accidents, Fukushima 4 to 5 million curies, Chernobyl 40 to 50 million, but the weapons testing in the 40s and 50s was 20 billion curies, and that was very close to Australia and New Zealand. We should be mindful of the radiation issue because as physicians and surgeons, we do inflict a fair amount of radiation on our patients, most of it life-saving, but it is important to be mindful of the fact that whenever we order an adult CT or a neonatal CT, we give 10 to 20 millisieverts of radiation. This is a pretty provocative paper from 2007 by Barrington where they modelled the cancer risk associated with the use of CT scan in the US, and they calculated that just as a result of the CT scans that were performed in 2007 in the US, there were probably 29,000 cancers that were going to come as a result of that. That was a model and yet to be proven, but it just, I think, reminds us to be mindful of the fact that when we order tests, particularly CAT scans, there are consequences for patients. I'm going to just take one slide to focus on the use of ultrasound, because really the quality of ultrasound in the last decade has changed dramatically. And for GPs and endocrinologists and endocrine surgeons who are dealing with thyroid nodules, we've gone beyond the point of just measuring simply the size of the nodule. We used to say if there's a nodule more than a centimetre, it needs to be biopsied, but that's no longer true. We know that these benign nodules and these very low suspicious spongiform nodules actually can be monitored and don't necessarily need to be biopsied. And in contrast, these very suspicious nodules which are hypoechoic with microcalcifications, you need to take them seriously. So if you get an FNA from a nodule like that that says it's benign, you don't necessarily always have to believe it. So ultrasound really is critical and probably our most valuable modality. I thought, rather than spend a lot of time talking about the data around surgery, I thought I'd just talk more anecdotally about the things that we've changed in surgical technique in the last 20 years. And this is a minor thing, but so important to patients, the placement of incisions. And increasingly, we are attempting to use skin crease incisions in thyroid surgery. Traditionally, the incision used to be low and down here, placed in the area of a pearl necklace, but we've found that these higher incisions placed directly in a skin crease give an excellent cosmetic result and actually make the surgery a little easier because they give us access to the critical part of the operation. So you'll probably see a trend towards incisions changing, flatter incisions and incisions placed in skin creases. The technology likewise has changed. No longer are we cutting and tying every single vessel. We're using these instruments, ligashore and harmonic scalpel. They allow us to be more accurate with our dissection. They actually make the surgery a little faster. Patients are on the table not as long. Complication rates are lower. The rate of hematomas following surgery has dropped. The rate of parathyroid damage following surgery has dropped. So these devices are extremely useful. Surgical technique also has advanced. We understand now that this previously really disregarded nerve, the external branch of the superior laryngeal nerve, is a very important nerve for voice quality. That nerve nowadays is recognised and preserved in over 90% of cases in the hands of surgeons with experience. We also know that if you want to avoid hypoparathyroidism, you've got to do a very careful dissection of the thyroid very close to the thyroid capsule. We understand, we've learnt about the anatomy and the blood supply of these parathyroids, and we know that if you hug the thyroid capsule here, you can drop that parathyroid down and preserve it, because hypocalcemia is actually a very troublesome post-operative complication, and it can be very easily avoided with the correct surgical technique. We've learnt a lot about how to save parathyroid tissue in cases where the parathyroid has been inadvertently devascularized. And we know that if you recognise that injury to the parathyroid early, you can mince the parathyroid up, use a balanced salt solution, cut it up into a number of tiny pieces, re-inject that into the sternomastoid muscle, and in over 95% of cases we get functioning parathyroid tissue from that parathyroid. So it's not quite zero, but the rate of hypoparathyroidism is approaching zero. You know, we're very much under 1% now. We're close to about 0.5%, and it's these tiny little incremental improvements in technique that have resulted in those good outcomes. The recurrent laryngeal nerve, as you all know, is a critical part of thyroid surgery. And up until 4 or 5 years ago, we really just used to eyeball the nerve. But now we've got a technology that allows us to monitor the nerve throughout the case. We know when we're stretching the nerve. We can learn when we're too close to it, when there's a thermal injury. And I think the neuromonitor now will result in a much lower rate of nerve injury. And it's rapidly becoming a routine part of thyroid surgery. The robotic surgery is definitely here, and it is starting to find its indications in surgery. It's certainly been well proven in prostatic surgery and surgery in the oral cavity. It's still finding its place in thyroid surgery. I was in Korea last month, and the Korean surgeons are actually very expert in using the robot. Their main motivation really is to avoid incisions in the neck, and as a result they instead of putting a 4 centimetre incision in the neck, they put an 8 centimetre incision in the armpit area and tunnel up and use the robot to access the thyroid. So it's still, look, I think thyroid surgery using the robot is still in its infancy, but it's here, and there are certainly some expertise being developed in Korea, and we continue to watch that space. So what constitutes a high-risk cancer? Geoff showed this slide, but it's any thyroid cancer where there is clear invasion of tumour outside of the thyroid. If there's incomplete resection of the tumour, distant metastasis, markedly elevated thyroglobulin levels, if you have a lymph node which is more than 3 centimetres, and in the setting of follicular thyroid cancer, if there are more than 4 foci of vascular invasion. For those patients, we still really are recommending total thyroidectomy, and that's not so controversial. Where the controversies arise is how aggressive to be with the lymph node surgery. In our experience, so this is the experience of over 1,200 cases of papillary thyroid cancer here at North Shore. If you look carefully, you'll find almost 50% of patients will have central compartment lymph node disease, not metastases died, just lymph nodes, and 20% will have lateral lymph node disease. Now, we appreciate that the presence of lymph nodes doesn't necessarily mean that the patient has a much increased risk of mortality, but nevertheless, those lymph nodes are troublesome. They cause anxiety to the endocrinologist. They cause elevated thyroglobulin levels. Geoff doesn't like it when patients turn up and there's lymph nodes all over the neck, and certainly patients experience anxiety associated with abnormal ultrasounds. So our focus has been on ensuring that when we do the thyroidectomy, at the very least we clear the central compartment. And if you use those parathyroid preserving techniques, you can do that with low complication rates. The thyroid ultrasound is poor at detecting central compartment lymph nodes, but actually quite good at determining the presence of metastatic disease in the lateral compartment. So as part of our operation for high-risk papillary thyroid carcinoma, we will routinely undertake a dissection of these central compartment lymph nodes, and it's a relatively small pocket of tissue that sits next to the thyroid and on either side of the nerve. This is a very problematic area to reoperate in if you leave lymph node disease behind, and it makes sense to clear that area out at the first operation. So an aggressive approach to lymph node really informs our endocrinologist and nuclear medicine physicians about the need for radioactive iodine. Some people are upstaged, some people are downstaged. It reduces the need for reoperative surgery, and in our hands it has certainly reduced thyroglobulin levels. When we've examined our experience here, patients who are at risk of recurrence in our hands are the very young and the very old, the 4 centimetre tumours and the poor actors, the insular and the tall cell cancers. These types of papillary thyroid cancers certainly warrant more careful attention and follow-up. Certainly the traditional markers of vascular, extrathyroidal and lymph node involvement are good predictors of recurrence, and we have been very convinced on the BRAF story, and you'll find that pathology reports that come out of North Shore always have a BRAF status. And I'll show you some data on that. Where do we fail as surgeons in papillary thyroid cancer? Well, this illustration just shows where our recurrences occur. About 8% of our patients will have a thyroid, a nodal recurrence that requires further surgery, and in most cases it's now in the lateral compartment. So our aggressive approach in the central compartment has almost entirely sorted out this area, but the lateral compartment is where we are still finding lymph nodes that need further surgery. Tracheal invasion that requires aggressive tracheal surgery actually is quite uncommon. The vast majority of our patients have this minor tracheal invasion that can be shaved off. Very rarely we're put in a situation where we've got to resect the trachea. Just to give you an idea of how often that happens, of the 34 cases of structural recurrence for papillary thyroid cancer in our experience, the vast majority were lymph nodes that could easily be managed with removing lymph nodes or injecting lymph nodes with alcohol now, which we occasionally do. Tracheal resection is pretty uncommon. Only 15% of that group needed tracheal resection, and certainly even more aggressive operations such as partial esophagectomy or laryngectomy are extremely rare. So if you're working in a practice and all of a sudden your thyroid cancer patients are coming back having had total laryngectomy or esophageal resections, it would be reasonable to ask your endocrine surgeon or head and neck surgeon whether that was really needed. We are using external beam radiotherapy more often for high-risk cancers, particularly insular carcinomas, but in general it's still a pretty low rate. The BRAF story is one that we have been convinced of here. There's a BRAF positive immunohistochemistry and a BRAF negative immunohistochemistry, and this is the survival curve, disease-free survival, and we found pretty clearly that the curves diverged. These BRAF negative patients certainly had fewer recurrences than our BRAF positive patients. And it may not just be BRAF that informs us on the genetic nature of these tumours. It might be the combination of BRAF and TERT, but I think we're not far from having surgery guided by the genetic signature of these tumours. Not all thyroid cancers can be treated surgically immediately. High-risk ones, that is, and anaplastic is one of those. This is an example of a patient who presented with an unresectable cancer at the outset. But once again, this algorithm has changed. We've now moved to avoiding surgery at the outset, pre-treating this patient with radiotherapy or a molecular agent, and then coming back and resecting something that is more likely to have a successful surgical outcome. So it's clear that the thyroid cancer burden in New South Wales is increased and across Australia. Small improvements in surgical technique over 50 years have really resulted in what in general are very, very good outcomes in terms of surgical complication rates. For high-risk cases, we are still advocating total thyroidectomy, and we are definitely moving towards a genetic signature for individual tumours that will help us guide the extent of our surgery and particularly the extent of our lymph node surgery. Thank you.
Fantastic. So our final speaker for the evening is Professor Bruce Robinson, an endocrinologist. His research is focused on identifying the genetic changes which either predispose or directly cause endocrine tumours, and amongst other highlights has been the formation of an international consortium of families from around the world to decipher and study medullary thyroid cancer of pheochromocytoma. He's been the head and remains the head of the Cancer Genetics Unit of the Colling Institute of Medical Research at North Shore from 1989, continues to practice at Royal North Shore Hospital. He's the chair of the NHMRC and chair of the MBS Review. Bruce, thank you very much indeed.
Well, thank you for inviting me to talk tonight, and thank you all for being here too. I only have a few slides to talk to you about the use of what are called systemic therapies, that is, therapies that are taken orally in this particular case, that are used in patients who've got to the stage in their disease where they're failing to respond to radioactive iodine that you've heard about tonight, which works in the vast majority of patients. So this is what we call advanced iodine refractory differentiated thyroid cancer. And I entitled this slide The Pros and Cons of Treatment, because this is not a cakewalk. and we do need to select patients very carefully for these treatments, just the same as we select carefully those patients who need radioactive iodine and those patients who may not need radioactive iodine. So there are a number of factors that one has to consider when talking to a patient about whether they are a candidate for this disease. Some of these we've already heard about tonight: the histologic subtype, the nasty subtypes that are listed there. We need to have a good appreciation of the actual volume of disease that a person has, how quickly that disease is growing, if there are any symptoms that are present at the moment, and if there are any symptoms that are likely to start developing. And then we need to think about what the treatment options might be. We need to also consider how well the treatment might work, what its limitations are, what are the side effects of it and the impact upon the quality of life, and overall what makes sense for the whole patient. So just as with all of the forms of thyroid cancer therapy that you've been hearing about tonight, this is very much personalised and dependent upon the patient and their particular needs. Now, I've touched on the nature of the disease and the rate of its progression. It's now generally fairly well regarded that progression of disease that's demonstrated on standard scans, particularly CT scans, over the preceding 12 to 14 months is a factor which really ought to be present before you consider a patient for one of these systemic therapies with what are known as tyrosine kinase inhibitors, or TKIs for short. As endocrinologists, we've had to get used to using this set of criteria called RESIST, which oncologists are all very well used to using for the trials that they undertake of drugs, chemotherapy drugs, but we have not been used to using those until relatively recently, and this is a set of criteria where we have to be able to demonstrate progression, which is defined as being a greater than or equal to 20% increase in the sum of the longest diameter of what are called the target lesions. So when you look at the scan of a patient, 2 scans taken 12 months apart, you have to pick a number of lesions and then decide that they're called the target lesions. You measure the longest diameter of each of those lumps of tumour, and you have to see a greater than or equal to 20% increase in the sum of the longest diameter of these target lesions before that qualifies as being defined as progression. We need to consider the burden of disease too, the total sum of disease that a person has, any symptoms that they might be experiencing from it, any other comorbid conditions that they might have as well, and of course we have to take into account the patient preference. When you describe the potential side effects of some of these drugs to patients, not all of them are willing to sign up. As I've said, this is not a cakewalk. We are still relatively in our infancy in learning how to manage these drugs, how to manage the dose of them, how to choose the starting dose, how to manage side effects should they begin to occur. So, 2 different examples of patients, one of whom might need treatment and another of whom might not. This patient, number 1, has metastatic papillary thyroid carcinoma with a number of small lung nodules that you can see on this CT scan in here. They also have a moderate-sized pleural effusion, they have cough, and they have shortness of breath. So this patient is quite clearly symptomatic, and I think most of us would agree that that patient is a good candidate for treatment. The second patient has metastatic Hürthle cell carcinoma. Again, small lung nodules seen on the scan here, no other disease that's relatively slowly progressive. The question is, does she really need treatment or not? And I think these are important questions that we need to ask, not just of ourselves, but also discuss clearly with the patient. So the question that now we are being asked increasingly by patients and by our colleagues is, why shouldn't everyone who's got iodine refractory recurrent metastatic differentiated thyroid cancer get treatment right now? And by getting treatment, all of these patients, if they're resistant to radioactive iodine, should also still be having suppressive thyroid hormone therapy, so treatment with thyroxine to keep their TSH low, because we know that's a factor that contributes to better outcomes. The reasons why we're even asking this question is that this treatment is not potentially curative. It helps to slow down the rate of progression of disease. We don't have very clear evidence about it prolonging life. And the other question that we don't have a good answer to is when we should actually start this treatment. These trials that have been undertaken, and I'll show you some data from shortly, have been undertaken in patients generally with fairly advanced disease. We still don't have an answer to the question as to whether that's the right patient to begin this treatment in. Should we begin the treatment in patients with earlier stage disease to get better benefit from it? And the second problem with these treatments is that almost everyone who is on these treatments will get some symptom side effects, and there will be some impact of the treatment on the quality of their life. Now, the main drug that I want to talk to you about tonight is a drug called lenvatinib, and I want to talk about lenvatinib because this is available on the Pharmaceutical Benefits Scheme for the treatment of poorly differentiated or iodine refractory thyroid cancer. The drug acts as what is called a tyrosine kinase inhibitor. What that means is that it's able to block the actions of these things here that are called receptors. Now, a receptor is a bit like a lock in a door, and if you look at the cell membrane here, this thing right along here as being the door, with the locks in the door, normally these molecules, like PDGF, like VEGF, like FGF, which are a bit like a key, come along, jump into the lock, unlock the receptor, and then cause something to happen inside the cell which makes the cell go on and divide. Well, what a drug like lenvatinib does, and there are a number of these drugs, what these drugs do is they block the receptor. They actually gum up the lock, so they stop this transduction of a signal into the centre of the cell, into the nucleus of the cell, which causes the cell to divide. Now, lenvatinib targets a number of these receptors, but it's particularly active on the FGF receptor, but it does have activity against these other receptors as well. So, to help try to evaluate this, Martin Schlumberger led a major study of lenvatinib that was called the SELECT study. Martin Schlumberger is a big name in thyroid cancer from Paris, who's done a lot of the work that Geoff referred to earlier about choosing the right dose of radioactive iodine in patients. And this study compared patients being treated with lenvatinib or placebo. There are a large number of patients, 360 patients, who all had iodine refractory, poorly differentiated thyroid cancer. They all had measurable disease because they had to qualify by having measurable disease to get into this study, and they all had to have evidence of disease which was progressive. So this is a group of patients who are getting towards the end of their thyroid cancer journey. And in this study, when patients who were on either the drug or the placebo started to show signs of further progression, then it was assumed that they might have been receiving placebo, and so they were switched onto the active drug. So that's what's called a crossover study. And then they were all followed up until their disease progressed. This slide shows the major result from this study, and that is the overall response rate. That is, about 65% of patients actually responded to this treatment. And here is what's called the progression-free survival curves. Now, this is the period of time that the patients are able to be held without progression of their disease in this study. And clearly you can see that in the patients on lenvatinib, there is progression. It does eventually occur. So over a 24-month period, about 60% of the patients had shown progression. But you can see here that patients on placebo had shown much greater rates of progression. So there was beginning to be certainly a lot of enthusiasm when this data was seen, where progression-free survival in the treated patients was 18 months compared to 4 months with placebo. And there was some emerging evidence at that stage of an overall survival benefit. That led to lenvatinib being approved by the FDA in early 2015, and then subsequently it went on to the Pharmaceutical Benefits Scheme here in Australia in 2016. There's relatively recently been some analysis of the overall survival data from the SELECT study, again showing a modest difference in the overall survival comparing patients treated with lenvatinib compared to patients treated with placebo. There is one other drug which is not uncommonly used. This is a drug called sorafenib, and I'm not standing up here doing a paid advertorial for lenvatinib, but this is the data showing the comparison of the progression-free survival curves for the drug sorafenib, which is another one of these tyrosine kinase inhibitors. Here is drug treatment, here is placebo, and that is in comparison with the results from the SELECT study, with the lenvatinib and placebo curves are shown here. This is exactly the same data that I showed you a couple of slides ago. So on that note, I might end. The purpose was really just to show you that for patients who do have radioactive iodine refractory thyroid cancer, this is a small percentage of patients, there are now treatments which are able to offer some hope of at least progression-free survival and perhaps a very modest increase in overall survival. Thank you very much.
So before I get the panel to come up and answer questions from the floor, I just want to invite Madeline Alnett to the podium to discuss the role of the Australian Thyroid Foundation in thyroid cancer patients.
Hello to everyone here today, and it certainly is a wonderful opportunity for the ATF to participate in this forum, and I know I so far have learnt an enormous amount. Might be difficult to retain, but have certainly learnt an enormous amount. I'm talking on behalf of our CEO, Bev Garside, who can't be here today, but I thank the other ATF members who also have joined. I also have had thyroid cancer and had it in my family as well, and so have many of the members of the Australian Thyroid Foundation, and we all speak with personal experience and have a lot to share amongst each other of what we've learned, how we've coped, and so forth. So if I just go on to the next slide. Okay, so we were founded in 1995, so we've got 22 years of collective experience of supporting people through their various thyroid disorder experiences, but also thyroid cancer patients as well. So we're formed for patient support and advocacy, and we are a not-for-profit, and we're there to really support thyroid cancer patients through their journey. We are the knowledgeable, I hope. We try to keep as up-to-date as we can. We're clearly not medical professionals, but we are the friendly voice at the end of the phone who can listen and, importantly, put people together to share their common concerns and work out best ways to be able to get through that journey. We work very closely with the experts in thyroid cancer, which is a privilege for us, and certainly we've had, very eminent people here today on the panel. We really encourage you to be very involved in your treatment and to ask questions, and I guess that's something that we can share, is to really help patients to be as planned in their consultations with their medical specialists so that they maximise what they get out of that experience. So again, we very much support the notion of a personalised care plan, which is very much what Rory said at the very beginning of this session today. We offer a website, members meetings, a newsletter, a newly developed Facebook group, so we're right into the whole social media thing now, where people can put up their query and we can share personal stories as well, which is great, and telephone support contacts who've been through the same or similar journeys. I shared a car ride with Cheryl, one of our members today, and her phone rang hot. So it's great that we can offer that kind of service. There's a lot of common questions that thyroid cancer patients have. Sometimes after they've had the consultation, when they've been told that they have thyroid cancer, they can't actually remember what it is that they were told. They can't remember the name of it. So it's really trying to reiterate again the questions that people need to ask, and also to help them understand where to go and get information too. We help them with the consequences of their treatment, be it thyroidectomy or hemithyroidectomy or radioactive iodine treatment. Whatever the plan is that's worked out, we can talk about the effects of that and the consequences. We help them understand the range of specialists who will be involved in their treatment too. So remembering it's all very unfamiliar to someone, you know, what's the difference between an endocrinologist and an endocrine surgeon? And so it's helping them to fathom all of that. We can help them understand treatment options like radioactive iodine. What does that do? What does that mean? What's thyrogen? What's that about? And why would you ask questions about that? PET scan, etc. Recovery, it's a journey for, I think, every person who goes on to, if they have a total thyroidectomy and they're going on to called now levothyroxine, I believe, instead of just thyroxine. But it's the regular blood tests. It's for thyroid cancer patients chasing thyroglobulin and thyroglobulin antibody markers as well. So it's understanding all that terminology and helping people to become more familiar with it. It's helping them to understand what time off work they might need, and in particular the journey of going on to thyroxine. You know, it takes some time to settle that down, and what effect will that have on you? What will that effect have on your family and work? The emotions, I think, are something that shouldn't be underestimated in the thyroid cancer journey, like any cancer journey. It's shock, anger, depression, confusion, and it's great that our members can share that story and how they coped with those emotions too. So certainly we are there to help people to do the best they can do through that journey and to share their thoughts and their emotions and answer their questions. So we would encourage anyone to utilise what we have to offer at the ATF. So thank you very much. Thanks, Laurie.
Thank you so much. All right, can I get the panel to come and sit down? And I'm going to stay standing to be the moderator. And now's the time to sharpen your vocal cords and ask all of those burning questions you have about thyroid cancer cases, thyroid cancer experience, thyroid cancer management, doubts, uncertainties, triumphs and disasters. Tony Morrow.
Hello, thank you very much. Diana, thank you for your talk, and in particular the PET scan. If I understood you, you actually showed non-Hodgkin thyroid cancer. Yeah. There must be a whole cohort of people now who have PET scans and find hotspots. You might have more than one.
Yep.
One patient walked into my office with a PET scan showing a hot nodule. It was done because his daughter-in-law worked at a radiology practice. His daughter-in-law worked at a radiology practice, and because of his melanoma, which was well resected, you know, opted to do a PET scan, and it showed up this hotspot, which, by the way, was eminently palpable, and he had his thyroid cancer removed. But so it's quite an intriguing observation that thyroid cancer is being diagnosed pre-ultrasound.
Yeah, no, and in fact we've got such good radiologists now that the radiologist had to go into the area that was not a nodule to do the biopsy to find the cancer, and the biopsy of the dominant nodule was benign. So that sort of signifies how early we're picking it up.
Because PET scans are commonly done for other cancers,
Yeah.
are you seeing
2.5% prevalence of hot uptake
of PET scans
on general PET scanning, yeah.
Then
And a third of those will be thyroid cancers, yeah.
Thank you for this informative speech. My question is to you, Dr. Diana, about your patient with Hashimoto's and similar cases here. Since she had higher thyroglobulin and antibody, how do you follow up her?
Well, I'm hoping that with time her thyroglobulin antibody titer will decline. That's less likely to happen because she hasn't had radioactive iodine. So my experience is that it usually becomes negative after radioactive iodine ablation when you're ablating any antigenic stimulus that might be left behind. So I'm just going to treat her with regular ultrasound, regular measurement of thyroglobulin antibodies, hoping that the titer will decline or at least not rise as a surrogate marker. We know that's not particularly reliable, but it's the best situation we have. And if there's no anatomical disease on ultrasound, then I will be reassured by that. But it's going to be challenging because she's very anxious, and I'm a bit anxious too, actually.
Thank you.
So I'm going to ask a question of Diana and Mark. With the use of central node dissection at North Shore, it's my anecdotal experience that it's not uncommon to get a patient with no detectable thyroid cancer marker, the thyroglobulin measurement that we routinely do after surgery. And so, Di and Mark, how reassuring is a thyroglobulin negative patient in determining the need for radioactive iodine? Can we dismiss radioiodine if the thyroglobulin is zero after surgery?
That was a topic of great debate in America when I was at the meeting, and Mike Tuttle was advocating that we routinely measure a serum thyroglobulin post-operatively before we make a decision about radioactive iodine, and that if the thyroglobulin is undetectable, that we don't necessarily proceed. It takes a while for thyroglobulin to come down post-operatively. The nadir is around about 6 weeks post-op, so you would have to defer your decision-making for a bit longer than we might routinely do. But you also need to be mindful of the fact that your delayed risk stratification might in fact upscale the patient. So you might find that the thyroglobulin in a high-risk histology is negative and then goes up again later, and you wish you had given radioactive iodine. So we're very lucky that we do have a lot of patients with undetectable thyroglobulins post-op because we've got such good surgeons, and if it's a very low-risk patient, I wouldn't give radioactive iodine. Yeah.
There still are a considerable number of patients who have a slightly raised thyroglobulin, and in our experience it's still about 30 or 40%, but I think we are getting more comfortable with just watching slight elevations in thyroglobulin and not panicking if the thyroglobulin is slightly elevated. You're not going to lose control of that patient, and there's no harm in waiting and just watching that thyroglobulin.
Mark, I was particularly interested with the staggering data with nuclear fallout. Do we know much about the winds from the Marshall Islands and from testing indeed within Australia, and whether that's affected thyroid cancer rates in our country?
I'm just surprised that few Australians really understand what happened. There's the Kiwis have got a large experience of thyroid cancer in patients who couldn't be treated in the Pacific Islands and had their surgery in New Zealand. But I don't think it's actually been very well studied. In contrast to Hiroshima and the Chernobyl accident, we know that the Americans, to their credit, after they dropped the bomb, they built a hospital a few months later in Hiroshima and very carefully studied what the after effects of the radiation, and we all learnt a lot from that. Similarly in Chernobyl, but sadly the Pacific Islanders didn't get that same attention. And Mike Tuttle tells an interesting anecdote. He says the US Navy came into the Marshall Islands and says, we're just going to borrow the islands for a little while to do the testing, but they didn't tell them that it was going to be 30,000 years before they can have them back.
Yes, please.
We have looked after so many patients from their history. Have you found out what is the disturbing factor that is causing this problem, affecting the thyroid gland, causing cancer? Is it environment? Is it food? Is it chemical? Is the lifestyle? What is the underlying cause? And as the incidence is going up, what can we do to help these people change their lifestyle, or whatever it is? Or is it genetic? Is it familial? Is the ethnic origin, which is the underlying cause of all this?
So there's been some work that it may be just ascertainment, and that we're picking up very early cancers that may normally never cause a problem because of a lot of ultrasound, but it's more than that. We know that it's more than that, and I don't think we know the answer. So maybe it is radiation exposure, maybe it's Western lifestyle, etc. It is more prevalent in Western society, isn't it? I'm pretty sure.
At a meeting that I was at earlier this year, there was a very provocative paper presented from Duke University suggesting that there was some very early data to show that one of the factors might be fire retardants that are used in household furniture. This is still very, very early days, but they were actually suggesting that this was perhaps one of the factors contributing to the increased incidence besides, as Di said, the ascertainment.
Bruce, with the treatments, the chemotherapies for thyroid cancer, there's toxicity involved. But yet in a country like Australia with such a geographically diverse population, it's hard to maintain equity of treatment. Do you think that everybody going on to these new toxic therapies needs specialised treatment in a tertiary centre? How do we manage the problem of the tyranny of distance in Australia?
Look, I think what we have to do is to gradually train more and more people to be able to manage these people in regional Australia too, because there's no real need for the patient to be brought to the drug. The drug can easily be delivered to the patient, but we do need people to have developed expertise with these drugs. There are really only 3 major centres in Australia that have been involved in the trials that we've talked about. That's us here at North Shore, the Alfred Hospital in Melbourne and the Royal Brisbane Hospital. So there is a real need for us to try to get more of these trial centres open in Australia. This is sometimes a battle though. The big pharmaceutical companies that run these trials often want to limit the number of study sites because it's expensive to open a study site, and it's easier to collect 20 patients from one site than it is to collect 5 patients from each of 4 sites. So once they go onto the PBS though, they should be available to anyone in the country, and then I think it's important that we undertake a fairly significant education program to make sure that people understand their use. And so to that end, we're actually doing a seminar at the Endocrine Society, as you know, Rory, in Perth in a few weeks to try to educate more endocrinologists to be able to use these drugs.
Maddie.
That a clinician has said or done to help you, would you tell us about that?
I think that it was more there's options. There's not just one particular way that's going to help you over your time. And being told it's more like a chronic illness in terms of things and managing it from that way. Yeah, and so it was sort of reassuring that way.
I was going to ask the same question slightly differently. If there's one thing you could change about your treatment in retrospect, what would you change? Not that you weren't, didn't get the best possible treatment, but what was the thing that irritated you most about thyroid cancer treatment?
I think not having enough information and not knowing the questions to ask, I guess. But I think once you sort of, get that first opinion, second opinion, talk to other people in similar situations, yeah, I would definitely have more of that. I wish I joined the Thyroid Foundation sooner, right. I guess, in terms of support, yeah.
So Geoff, with the decreasing use of radioactive iodine, the lower doses need fewer hospital days. Do we see that reflected in the bed stays in North Shore? Are we treating more patients for a shorter duration of time?
So I think the total numbers have actually surprisingly stayed pretty much the same over the last 5 or 6 years. We haven't seen a general decrease in numbers. Now that may be that we're not seeing the increase we could have expected with the increase in the population. So in fact there is probably a genuine reduction there. But certainly we are treating a lot of patients now with simply 1-day stays to 2-day stays. And I think the pressure on our rooms, once upon a time you had to fight tooth and nail to get a room, but now we pretty much can get a room within 3-4 weeks notice without any trouble. So I think there has been a benefit to us that the pressure's off the rooms.
Madeline.
Has there been any research done about the link, or any possible link, if it exists, between autoimmune thyroid disorders and developing thyroid cancer?
Oh, that's very controversial. So some studies show a link, others don't. I have to say it's a bit hard to study because you're seeing a lot of autoimmune thyroid disease, and they're the ones that are having ultrasounds and monitoring and doctor's visits. So it's going to be very difficult to do a good study to demonstrate yes or no. What do you think, Bruce?
Very very difficult to actually prove or disprove this. I think remains controversial.
There is one school of thought that in fact autoimmune thyroid disease may help contain thyroid cancer because it's, if you like, the unique immunotherapy for thyroid cancer that's innate to people with Hashimoto's disease. So there is some data around that. Yeah.
Hello, a question to the panel. I'm one of the endocrine past trainees in John Hunter Hospital. Just wanted to ask whether there is any association of low dose maintenance of anti-thyroid drugs has any influence on the appearance of thyroid cancer later in their life. If they had a hypothyroidism and they are maintenance dose of anti-thyroid medication, is there any association of that with the appearance of thyroid cancer in the later part of their life?
There's data on TSH levels in populations, but hopefully anyone who's on long-term anti-thyroid drugs would have their TSH maintained in the normal range. I don't use a lot of long-term neomercazole, but most of my Graves patients have fairly low TSHs, not high. Is that what you're asking? But there's certainly data, population data, that if your TSH level is a bit above another population, that you have a slightly higher thyroid cancer risk. I think that's true, isn't it, Rory?
Yeah, absolutely. But I don't think that's specific to being on the anti-thyroid drug. It's a reflection of the TSH. Mark, you've got to get one of those robots, don't you? You've got 2 or 3 parked over in Northbrook Private Hospital.
It has been discussed. Some people think it's a gimmick,
the chair of the MBS review thinks it's a gimmick.
But the surgeons who have become quite adept at using it believe that the magnification and the control and the movement ultimately will improve outcomes. So we're still watching it, and we don't have one here, so I guess it's an easy decision so far. But when they do buy one at North Shore, then we'll have to think hard about whether it benefits patients.
What we'll do is we'll put it on the medical benefit schedule, but at half the fee of a standard thyroidectomy, and we'll see how much take-up there is.
Alexander.
Mark, isn't going to be awfully difficult to prove any benefits of a robot in a program that has such excellent results? You're going to have to do 1,000 or 10,000 to show any benefits. So isn't actually the discussion about the robot what we sort of skipped over a bit, but isn't the volume outcome discussion and getting teams that are sufficiently exposed to all forms? It's almost like your difficult cases become routine. I think that's the essence of surgical oncological teams.
Yeah, and the difficulty about the robot in thyroid surgery is that it's actually all about cosmesis. It's only about cosmesis. I know, we're focused on nerves and parathyroids. That's what we really care about. I mean, we care about cosmesis too, but it may be that certainly when surgeons start in their learning curve on the robot, they will compromise some of those hard outcomes. But there are surgeons in this room, and if you're a young surgeon coming through, you don't necessarily want to be left behind because you don't believe in the technology. We all want to keep in touch with the technology. So at some point, you do have to put your foot in the water.
Karen.
At what point you kind of decide that a patient is cured and ease the monitoring, and how do you ease that? Where do you kind of let go?
I agonise about this a lot. I certainly see patients less frequently when they're 10 years down the track and they had a low-risk disease and they've never caused concern or had recurrence, and I say come back in 2 or 3 years. I have had patients recur after I have had a patient recur after 17 years of being in complete remission, although she did have a different histology. She had a Hurtle cell cancer, and that has made me nervous about saying ta-ta forever. And in the meeting in Boston, they addressed this again and said we need more studies to answer that question. But yeah, I'm mindful of the cost to the community, so I'm doing a lot fewer routine surveillance neck ultrasounds than I used to do. And I think there's data on that too, that we're probably doing too many. And if thyroglobulin, I'm just trying to teach the GPs about thyroglobulin so that they will do it routinely every year, and then if that starts to rise, that's a warning sign to come back to see me. But that's a very hard message to get across, I must say.
Almost as hard as the message that TSH suppression remains important. We see patients coming back all the time who've had their thyroxine dose reduced because the GP is worried that they're over-replaced.
Although we are definitely reducing our level of TSH suppression in low-risk patients now, particularly when they get into menopause and they've got risks for low bone density, etc.
Yep.
Can I just say something there? I am a cancer survivor, 13 years. My endo wants me to have ultrasound the rest of my life. And I said, that's not the guidelines. And they looked it up and they said, oh no, you're right. And I've changed an endo again, and he wants to have it done every year too. And I said, no, I think I've had enough. And I said, I'm happy to just go and buy the blood tests. I'll buy global. So
it depends on the situation and the type of tumour, and you know, it depends on
at the time.
Yeah, if it's completely cured and you're in remission, you certainly don't need an annual ultrasound if your thyroglobulin is negative.
Yeah, that's my issue, and so I'm telling them. Yeah. So I'm giving that support back to them.
Quick question from Mark Sywak.
Rory, a question, thank you. A question for Madeline, actually. Now, 1 in 7 Australians have some form of thyroid disease. I think that's the statistic. Do you feel like the profile of the ATF is at a level that reflects the widespread nature of thyroid disease in Australia?
No, I don't think it is. Sorry, I don't think it is at the level that it needs to be. We work very hard, and we've tried to have meetings for members in various states, but you know, I come from Melbourne, but we don't have any meeting structure there. We're beginning to, I guess, spread our wings a bit more, but it is difficult. I think this is where it's important to have the support of the medical profession to, you know, also advertise, if that's the word for it, of what support that we can actually give. And you know, further to a point that was just raised before about educating the doctors, it's a really good thing that the ATF can educate their members to ask the salient questions to the doctors, because they may not know about, you know, some aspects, because, you know, they can't necessarily be at that depth on every issue that they're dealing with. So, you know, I think we have a place. I think, do we need a bigger place? Yes, we need a bigger place, given that it's rising at such a rapid rate.
Bruce?
I think one thing that I've certainly been given some thought to, and many of us have too, and that is that we need to develop some material, much as is available for patients who've just been diagnosed with breast cancer. There is a brochure for breast cancer patients that I think lists 11 or 12 questions that a breast cancer patient should ask their treating doctor. And we need now to have, as you've heard tonight, this can be quite personalised, the approach that's taken to you, and I think it would be good if all patients were armed with those questions when they went in to see their doctor. Cancer Australia has developed it, and it's a great aid, I think, for patients.
Yes, I know Bev's very keen on getting, you know, some good written material, brochures that people can access very easily to help, you know, do that level of education that people need in the situation, because you don't necessarily remember every question to ask in every consultation. So that's a role that the ATF can certainly broaden out and get to maximum number of people.
So I'm going to summarise what we've heard tonight. I think this has been a great session. It's terrific to initiate this community engagement in a disease which clearly affects more and more Australians, and which, as Madeline's just said, we're not getting the knowledge out to the community. And so this is a wonderful opportunity for an expert centre to reach out to the community to increase the knowledge base and spread the message. So Di Learoyd very clearly illustrated that not all thyroid cancer is complex and needs very high level therapy, that a personalised treatment approach which matches the level of treatment required to the individual patient is essential. And for a group of patients with low-risk disease, either no surgery or minimal surgery may in fact be adequate treatment, full stop. Di also beautifully illustrated the way that endocrinologists and thyroid cancer physicians make these decisions, and for the training specialists in the audience, I think a take-home message is to use the American Thyroid Association risk, low, intermediate and high. This is now in routine clinical use in thyroid cancer practice, rather than the more traditional cancer staging procedures, the AGCC, which I don't think are nearly as useful. So low, intermediate and high risk is the way to go. Geoff Schembri then gave a wonderful talk on still the mainstay of containing thyroid cancer with the use of radioactive iodine. Undeniably a brilliant achievement in medicine 50 plus years ago, and still the treatment that we reach to when patients need non-surgical treatment for their thyroid cancer. Radioactive iodine is wonderfully effective at containing, controlling and eliminating residual disease. Mark Sywak, we think of surgery as a learnt art, but it continually evolves, and we're so blessed at North Shore to have the three best surgeons in Australia working at this hospital, Mark, Stan Sidhu and Lee Delbridge, who I think between them operate on nearly half of the thyroid cancer cases in New South Wales, and clearly the predominant thyroid cancer centre in Australia. And Mark, again, beautifully illustrated the way that new surgical techniques are achieving best results with minimum cosmetic impact to patients. And then Bruce Robinson illustrated how patients, when they've escaped from the clinical effect of radioactive iodine, have new hope with the advent of more powerful agents such as sorafenib and lenvatinib, which are clinically effective and are offering new hope for patients with otherwise progressive intractable thyroid cancer. So thank you very much to all of the panel. It's been a fantastic evening. Thank you to the audience. And I just want to thank four people. I want to thank Amber for coming. That was a wonderful opportunity for us to meet patients, and patient stories are so compelling. I want to thank Madeline. I think partnership with cancer support agencies are absolutely vital, both for clinicians and researchers. They're going to be the lifeblood of funding support into the future, and we're very pleased that the ATF was represented here tonight. I want to thank Sydney Vital. This is really a terrific forum to engage, and thank you very much for organising this and supporting this. And finally, I just want to acknowledge ISI, who a company involved in thyroid cancer treatment, who've also generously supported tonight's event. So thank you very much indeed. And I believe there are some drinks outside.